Manually rotate the head into an occiput anterior position. If she was fully dilated, then you could attempt to rotate the head with the forceps. That's the end of our quick review. Let's go back to Dr. Lewis.
All right, we're going to switch gears again. We're going to talk about obstetric emergencies. So these are the times where things get really, really hairy and time is of the essence and it can make everyone really, really nervous. So first one, fetal bradycardia. So we've discussed accelerations and decelerations before. Now let's talk about bradycardia. If the fetal heart rate drops below 100 or 110 for longer than about 2 minutes, we term this prolonged deceleration. Now, if it lasts more than 10 minutes, then we call it bradycardia. And the further you go down in fetal heart rate, the worse it is. So if you have a 60 is obviously worse than a 95. Bradycardia is associated with placental abruption, cord prolapse, uterine rupture, pulmonary embolus, amniotic fluid embolus, and seizures. So let's go through how we diagnose what's causing this fetal bradycardia, because these are life-threatening situations. First, confirm that, and this is a thing that you will get wrong. You will really freak out one of these days and you'll feel stupid. But first, confirm that it's the fetal heart rate that you're measuring here. Fetal bradycardia and not the monitor picking up the maternal heart rate. So you'll sit there and you go, oh my gosh, the fetal heart rate is 80, and then you know, the nurse right there is next to you going, nah, don't worry about it, that's just maternal heart rate. Especially as that baby moves further down, that monitor will have a harder time picking up the fetal heart tone. So first, make sure it's the actual right heart rate that you're looking at. Second, look at the mother. You know, because we talked about the causes here that will lead to this bradycardia, and half of them are maternal. So remember that if you don't have a healthy mom, you can't have a healthy baby. So you're looking for problems like pulmonary embolism, amniotic fluid embolus, and seizure. So look at vital signs, look at the patient examiner. Next, evaluate for any vaginal bleeding. If there's more than expected, then you have to think about placental abruption. If you don't know about placentation, like you don't have an ultrasound anywhere and maybe you're just seeing this patient for the first time, then you have to think about placental previa. So after that, you're going to do a vaginal exam, right? No, you're not going to do one because I've told you 14 times, never do a vaginal exam on a placenta previa. So you're going to want to do an ultrasound if you do have vaginal bleeding, you don't know if there's a placenta previa. You're probably not going to spend the time to do that right now because we're in a more emergent situation, but at least always keep that in the back of your head, vaginal bleeding and all that type of stuff. If placenta previa is not likely, then you want to continue with a vaginal exam. So you're going to check for dilation, effacement, station, position, all that great stuff. You want to check for cord prolapse. So if you have a cord prolapse, hopefully you don't feel that, because if you do, then you might have your hand stuck in there, especially if you feel like you caused the cord prolapse, because you have to keep the pressure off that cord in order to keep that baby alive. At the same time that you're doing your vaginal exam, you can feel the abdomen as well. Check for a prolonged uterine contraction, see if there's anything major going on pain-wise. You also want to make sure that you don't feel anything like a uterine rupture. And what will happen when you have a uterine rupture? Well, you're going to feel that position kind of shift upwards. You're going to feel like the baby's a lot higher than it was before because there's no longer pressure keeping the baby down. It kind of pops up, so you're like, oh gosh, that's not normal. We'll talk about that in a little bit as well. Finally, if the bradycardia persists, then you look to see if the baby is low enough in station to perform an operative delivery with forceps or a vacuum extraction. We'll talk about that here in a little bit as well. So treatment. So we've evaluated the patient. We've kind of figured out maybe what's going on, maybe we haven't. For prolonged decels and bradycardia, the first thing you want to do is move the mother onto either the left or the right lateral decubitus position. A lot of times we're going to do the left one by default, but right's not terrible either. And this will serve to decrease any potential compression of the baby on the maternal inferior vena cava. So you're going to have more blood flowing into the placenta as well, and you're going to get better perfusion, and that can help as well. This can also help with getting the baby off of potential compressed umbilical cords. You know, so if it's maybe not a cord prolapse, but if you're getting some compression on the umbilical cord, maybe just the shifting of that body weight may potentially get that baby off the cord as well and get you some good results as well. You're also going to put oxygen on the patient. So oxygen by face mask, you can put it on the mom. She's on her left, she's taking that. Underlying conditions, if they've been discovered, you want to attack those. So if the patient is hypotensive, then IV fluids. You know, if you see something else going on, address it. If bradycardia persists and the mother is stable, then either the baby is low, then either a couple of things can happen. If that baby is low enough for an operative delivery, then you can attempt that. If vaginal delivery is imminent, and sometimes this will happen as well, is that mom is pushing, they're right close to delivery, and then you're seeing some kind of worrisome looking decels. If they're about to get that baby out, then you can have that happen. But if we're not in those situations, then an immediate C-section is indicated. So if you're seeing prolonged bradycardia and you're like, this baby ain't coming out anytime soon, the decision needs to be very, very rapid. Probably what you need to be doing is, while you're making the decision, start getting that patient into the OR. Start prepping, getting anesthesia, get everything that you need while you're making this decision. Now, if you deliver vaginally in the operating room, there's nothing wrong with that. So if you need to do an operative delivery there, great. But you need to start getting the wheels in motion, that as that bradycardia persists, that you are imminently getting ready for a C-section. All right, now we're going to talk about shoulder dystocia. Now, this can produce very anxious moments in the delivery room. This can be very, very scary. These are very dreaded. So now it's defined as the need for additional obstetric maneuvers to affect delivery of the fetal shoulders at the time of vaginal delivery. So basically, you have to do extra stuff to get this baby out because that shoulder is stuck. Now, it occurs at about a rate of 0.2 upwards to 3% of all births, depending on whose study you're using. And they're very, very difficult to predict. I mean, sometimes you can look at certain scenarios, and we'll talk about those in a minute. Now, this is what happens. So the baby's head delivers, and you're like, yay, baby. And then you get sort of this, almost like this weird suction back, and the head gets kind of pinned up against the mom's perineum. You'll hear this referred to as the turtle sign. Now, if you're a person who curses a lot, this would be a good time where you might want to hold that back for the sake of the mother and the room in general. Because when you see this happen, you're going to really want to say, oh, fiddlesticks. Because this is sort of like your dreaded moment of delivering a baby. Everything's happy, everyone's around, family's all like, hey, here comes the baby, and then you're like, uh-oh, this could go really bad really fast. So it's due to this impaction of the anterior shoulder getting rammed and wedged up against the anterior, the area of the pubic symphysis. So it's not a soft tissue problem, it's a bony problem. You've got a bony shoulder coming up against a bony pubic symphysis. Risk factors for this, and there are some that you can be on the lookout for. So obviously, fetal macrosomia. If you've got a big-headed fat baby, there's going to be a greater chance of having a dystocia. So things like gestational diabetes or just overt pre-pregnancy diabetes. Previous shoulder dystocia, so if you have a patient who's had previous problems with dystocias, they're at high risk of getting them again. Maternal obesity, which we're having all the time now in America because everyone's obese in America. Post-term pregnancy, so that's again, you're going to have a bigger baby. Prolonged second stage of labor, and then operative vaginal delivery leads to more dystocias as well. Fetal complications, and this is the big time. This is when lawsuits run amok in the OB-GYN arena. So fetal complications due to the shoulder dystocia include brachial plexus nerve injuries, also referred to as herb palsy. You'll get a test on that 100 times in your medical career. Phrenic nerve palsy, fracture of the humerus and the clavicle, hypoxic brain injury, and death. So very, very, very serious stuff, and that's why this is so scary. Treatment. Now, most labor and delivery rooms will have a button on the wall that you push when a shoulder dystocia occurs. Oftentimes this will alert an alarm, blue lights will go off. Every hospital is different, kind of depending on how big the hospital is. So first, push the button. And then everyone should become running. There should be an alarm. You need a lot of help in these situations, especially for the maneuvers we're about to talk about. Time is very important here because the shoulder dystocia can cause complete compression of the umbilical cord, and that's when you get to that hypoxic brain injury and death stuff. All right, so there's a series of maneuvers, and this is something you really need to memorize, not just for testing, but during a shoulder dystocia, things are going bananas. Alarms are going off, 5 nurses have rushed in, 2 other doctors, hopefully, who are maybe on the floor are coming in. There's family members everywhere. People are crying. It's going nuts. So this is stuff that just needs to roll out of your mind in a very rapid scenario. And you don't want to be thinking, what was the third maneuver? I don't know, because people are going to be yelling and screaming and going crazy. Hopefully not. Hopefully things are calm and it's done correctly. So the first one is called McRoberts maneuver. Now this is the first one you should probably try. So 2 people basically grab the maternal legs and sharply flexes the thighs back against the abdomen. So basically you're just taking the mom and you're just going bonk, and you're just crunching her up. Now this decreases the inclination of the pelvis and thus increases the anterior posterior diameter, which can then free the anterior shoulder. So you're just kind of trying to angle this bigger, have the pelvis present in its largest diameter as best you can, and then try to get that anterior shoulder out. Sometimes while you're doing McRoberts, you can do what's called suprapubic pressure. That's number 2. So you're applying pressure suprapubically with the palm or the fist. Most of the time we're using fist because we're amped up. You're pushing down, you're directing that pressure on the anterior shoulder. So the anterior shoulder is stuck underneath the pubic symphysis, so you're trying to push it down underneath, and you can push it a little laterally as well. That'll kind of help slip it underneath that pubic symphysis. The next one is called the Rubin maneuver. So you're applying pressure to an accessible shoulder. So most of the time, you know, the anterior shoulder is anterior, so you're more likely to go in. So you kind of get behind that shoulder, and then you're going to push towards the anterior chest. So you're basically trying to kind of squish that shoulder in like this. You're not necessarily rotating the infant. You're really just kind of smushing things in like that and trying to decrease the overall diameter of those shoulders to then slip the anterior shoulder underneath the pubic symphysis. Next is the Woods corkscrew maneuver. So this is where we're actually rotating. So we're not just kind of squishing, we're actually rotating the fetus as best we can. So you're rotating hopefully by about 180 degrees if you can. You apply pressure to the anterior side of the posterior shoulder. So you're going to go underneath, you're going to find that shoulder, and you're going to try to put 2 or 3 fingers on there depending on how much room you have, and you're going to try to push around. Now you can also go on top of that and go on the back side of the anterior shoulder, and you're going to try to rotate those shoulders, and as you rotate the shoulders, hopefully you get it unstuck and it comes out as well. And most of the time you're going counterclockwise in that position. You can do kind of a reverse corkscrew depending on the position and everything, one direction or other, but counterclockwise is kind of the way that it's described. The last one is delivery of the posterior arm or shoulder. So if you have an arm like this, and imagine this is my posterior shoulder, you try to get in there if you got enough room to grab this arm, and you basically sweep it across the arm, the abdomen, the chest like this, and then you try to get it out like that. And once you get that arm out, then hopefully you can get the anterior arm out as well. So you're kind of sweeping it around, you're trying to pull it out like this. All right, so those are the major maneuvers. So what if the baby is still not out? So you're reaching new panic levels at this point. Well, rapidly try them again. You know, I mean, and we're talking about the matter of seconds. We're not sitting there like thinking that, I wonder if this maneuver will work, and then do it for 5 minutes, and then, well, that one didn't work. No, this is like boom, boom, you're getting them up, you're doing that, you're pushing it down. That one didn't work. Do it, do it, do it. I mean, you're doing these in the matter of seconds. You're moving very, very quickly. So you can try them again. You know, things can kind of dislodge. Sometimes it's the process. You get it going, but you're still moving very, very quick. Then we get into the scary things that you can do that hopefully you don't have to do. You can try cutting or fracturing the fetal clavicle. I've never had to do this, and I've heard it's actually really, really hard. You think it's a baby's clavicle, you just go in there and go and do it, but apparently it's really freaking hard to break a clavicle. Even worse, you can try cutting the maternal pubic symphysis. I've never seen or even heard that done, and that's supposed to end up actually quite horribly afterwards with healing up. The other thing, finally, if nothing works, you can try the Zavanelli maneuver, and this is basically you're pushing the baby back in, and then you go do a C-section. And I've never seen that done as well, but apparently if all things are going badly, then that's sort of your last resort. All right, so you know what to do with shoulder dystocia now. Let's move on to uterine rupture. So this is obviously another emergency. Extremely rare in patients without a uterine scar. But patients with a uterine scar, this is usually due to a C-section, and here in the United States we have plenty of C-sections, so there's lots of uterine scars out there. The uterine rupture rate during labor is 0.5 to 1%. Most people will say 1 in 200, they'll go with that 0.5%. Now the signs of a uterine rupture is fetal heart rate deceleration or bradycardia. So if you see a rapid down on your bradycardia, uterine rupture needs to be in your brain, especially if you're in a situation where you're in a VBAC or vaginal birth after cesarean section. So if you have someone who's had a C-section, they're trying to do labor, if you see a rapid deceleration or bradycardia, think of uterine rupture. Now the patient will experience sudden severe abdominal pain. It'll be sort of this tearing, sometimes they'll refer to it as a popping sensation because their uterus just popped. On exam, the baby will be suddenly a lot higher. We talked about this just a minute ago. It's like before, it's like the baby was further down, and now that fundus is kind of coming up, and it feels weird.